Parkinsonism. First, we learn what's the definition of Parkinson. First of all, it's a chronic, progressive, degenerative disorder. Okay, and it mainly involves the basal ganglia. And most of the time it is idiopathic, and that is seen in elderly people. And it is idiopathic variety, what is known as Parkinson disease. Which I'll be writing as PD. But otherwise there are certain other conditions where this can develop, and this is known as secondary Parkinson. In total, they are known as Parkinsonism. Next, they are characterized by classical feature of tremors, rigidity, hypokinesia, and gait disturbance. Right? Well, out of the three cardinal signs, the first three, that is resting tremor, rigidity, and bradykinesia, they are the three cardinal signs of Parkinson. Well, now when we talk about this thing, as I told you, it's a disease of the elderly people, and we need to have at least two features in a patient to diagnose a case of Parkinson. Why it is so important to talk about this? Because by and large, till now, majority of cases we diagnose by clinical examination only, because in these cases, usual investigation CT and MRI, routine CT MRI are normal. But something new has come up. What the new, I'll discuss soon. But as of now, routine CT, routine MRI are normal in this case. Now, what is the site of disease? As I told you, basal ganglia is the site of disease. You can see a schematic diagram. This is corpus striatum, that is putamen and caudate, and this is globus pallidus. Same thing, we can see striatum, globus pallidus, and in this main thing is substantia nigra, and subthalamic nucleus. You can see this thing. Now, why it is so important to show you this? Because in this case, classically, there is involvement of nigrostriatal pathway. Okay, and that leads to loss of nerve cells in substantia nigra. This is the classical picture, beautiful picture of substantia nigra, and this is corpus striatum, and this is the nigrostriatal pathway, which is primarily involved in these cases. Okay, well, symptoms occur when at least 80% of the cells are damaged. That's why it occurs in a little elderly people, not in a very young patient. It is involved. Now, what is the basic problem? In this nigrostriatal pathway, there are two neurotransmitters. One is acetylcholine, and other is dopamine. And normally they are in balance. And in this disease, dopamine level is reduced. So this I can write like this. This is A is acetylcholine and D is dopamine. Normally they are in balance, but in this disease, A level is high and dopamine level is reduced. So this mismatch between acetylcholine and dopamine. Let me explain to you. This is the acetylcholine and this is dopamine. I told you dopamine level goes down. So our aim of treatment is to make a balance. So we can do by two ways. Either we can give any drug which is dopaminergic drug, or we can give a anticholinergic drug. ठीक है? So dopaminergic drug or we can give anticholinergic drug. Ultimate aim is to make a balance between the two neurotransmitter. So the basic principle of treatment shall be either I give a anticholinergic drug or I give a dopaminergic drug, and this is how the balance is restored. And with this simple basic concept, now when I will be talking to you regarding treatment, your concepts will be very, very clear ki why we are using this drug and what is the advantage of using this drug. So with this background of basic concept, let's talk about what are the features, clinical features. General, expressionless, mask-like face. And this is known as hypomimia. Right? And patient has straight look. And infrequent blinking. This is what the facial appearance is. And rapid monotonous speech. Flex posture, that is, there is universal flexion. Patient is stooping forward to be more precise, and usually patient has constipation is usually a features. Of course, this can be added by, if you are patient giving anticholinergic drug, it can add to this problem. Now what else is there? So after general feature, we talk about tremors. Tremors are resting tremors. 4 to 8 per second, and they decrease on movement. Next point, that it usually start in thumb. Usually to begin with unilateral, but later on bilateral can be there and other fingers may also be involved. And in this patient, pill rolling movements are seen. Rigidity is usually cogwheel rigidity. And it is best elicited in the wrist joint. Some patients have plastic or so-called lead pipe rigidity, and it is usually seen more in the legs. And some patients have truncal rigidity, and that's the reason why they have flexed posture, so-called stooped posture. Well, one more problem which is there in this patient is hypokinesia. Movements are very slow. That means the patient has to pick up something. Like look at me, look at my hand. Suppose patient has to pick up a glass, like the way, this is the glass I picked up. But now, let's presume it's a table, okay, and there's a glass is there. And normally we pick up like this. But in these patients, the hand come like this. And this is how they pick up. That means the movement are very slow. In fact, out of all the problems, this is the most disturbing for the patient. This is really very annoying, very depressing for the patient that movement are very, very slow. Right? Well, then we talk more about gait. I told you patient has stoop posture, but gait and even postural reflexes are also disturbed. difficulty in maintaining the balance, slow to start walking, shortened stride, rapid small tendency to run, but they are stopped. But what the classical feature, and this tendency to run is known as fascinating gait. What else? Reduce arm swing. This is visible from a distance. Normally when we walk, we move our hand like this, and this arm movement is not there, and patient walk straight like this. Okay, point to be noted very carefully. Next point, patient has difficulty in stopping suddenly, and patient has difficulty in turning around. That means if he has to turn around, patient takes some time or it's not easy. So neither patient can stop suddenly, neither patient can turn around very easily, and even it is difficult to start also, but once he start, it tend to run, having fascinating gait, trying to catch his own gravity is what we talk about fascinating gait, the flex posture of course. Now, handwriting is small, and what is this known as micrographia? Now I have a question for you. After listening to question, stop the video, write down the answer. The question is, in which condition you get macrographia? That is, handwriting become bigger and bigger. Macrographia. And I'm sure by now you have written the answer. The answer of macrographia is hepatic encephalopathy. In fact, it is one of the earliest features of hepatic encephalopathy. What are the eye signs that we see in Parkinsonism? The eye signs seen are mnemonic is 3 R's, 2 K and 1 I. R, K and I. Reflex blepharospasm. Retraction of upper lid, so-called Collier sign. Red eye, this is external disease. Cogwheeling of the eye movement, that is hypometric skates and scatic pursuits. Keratitis due to dry eyes and infrequent blinking. So mnemonic is R3 K2I. Eye signs. Now let's talk about what are the causes of Parkinson. Impaired release of dopamine, this is the main problem in Parkinson disease. And I told you Parkinson disease is a type of idiopathic, primary and seen in elderly people. This is the most common cause. And drug depleting dopamine store. Obviously, any drug which will lead to depletion of dopamine, because now you know the basic concept that either reduce dopamine or is the main cause. So any drug like reserpine, although not used nowadays, tetrabenazine, these are the so-called dopamine depleting drug, or any dopamine antagonist drug will produce like this problem. Trauma, repeated head injury, and this is known as punch drunk disease. And if I don't talk about one person, then the discussion of Parkinson is incomplete. One of the greatest boxer of current era, Mr. Muhammad Ali, he suffered in the late phase of his life. But that is professional hazard. But what I want to say about him, I say he is the greatest boxer of the current era. But above that, he was the greatest human being also. And see his history, see and the way he talks. Greatest human being, a great man with the crown to touch personality, extraordinary hardworking, and he is a source of inspiration for all of us. How? And he came from very low profile family. He worked hard in his life to achieve the greatest success in the life, and as a mark of respect, he recently died, and I have a lot of love and regard for him. I bow my head in respect for that great human being, and because he is a source of inspiration for me also, how to hard work to achieve success. Well, because not everything we read for exam point of view, we have to learn many more things in the life to improve ourselves, to work hard. So with this background, now we talk about blockage of striatal dopamine receptor, phenothiazine, butyrylphenol, and copper deposition in the basal ganglia. This is typically what we see in Wilson disease. Wilson disease is an autosomal recessive disorder of copper metabolism and typically occurs in young patients. And remember, Parkinson's disease is a disease of the elderly person. So if you happen to see any patient below 40 years and he has Parkinson-like feature, you should always suspect about Wilson disease. So if you are suspecting Wilson disease, send the patient to a eye specialist, ophthalmologist. He will do the slit line examination. He like to look for the KF ring in the upper and lower quadrant of the eye, and that is one of the earliest, but the easiest way to look for the Wilson disease. And of course, you will investigate later on. And regarding Wilson disease, I have recorded another lecture. You can see detail in that lecture. Now, we talk about investigation for a case of Parkinson's disease. As of now, there is no specific test. I told you in the very beginning, routine CT, routine MRI are normal. But what the latest thing has come up now, which is again, this investigation is not a routine investigation, not available everywhere. We look for the dihydrotetrabenazine PET. It's a marker of VMT2. This you see a healthy person, and this we see in Parkinson's disease. There is a reduced striatal uptake of the tracer, which is most pronounced in the posterior putamen and tend to be asymmetrical. So this is a new thing has come up. This help in the diagnosis, but as I told you, it's a very expensive investigation, not routinely available. So by and large, if you have to talk about exam point of view, I still say that there is no specific investigation for a routine patient. Now, how to treat a case of Parkinson. But before I talk about treatment, we should know what are the drugs that we use in Parkinson. MAO-B inhibitor, and they include saligelins, and they include rezagelin. Okay, and they lead to insomnia and elderly patient. But how they really act? They reduce the breakdown of dopamine. So they will increase the concentration of dopamine. And one more thing, whenever you are prescribing this MAO-B inhibitor, patient should be avoided, told not to take a specific food. It's a question for you. Which food patient should be avoided if he is on MAO-B inhibitor? Write down the answer. Well, the food which is to be avoided is cheese. Why? It contains tyramine. And that can, if the patient take cheese with MAO-B inhibitor, it can precipitate severe hypertension. Now, central anticholinergic drug, and they include list of drug is in front of you. Trihexyphenidyl is the most commonly used drug, and benztropine is the drug of choice for drug-induced Parkinsonism. But the side effects are dry mouth, constipation are the two, and of course it can also reduce some memory also. That's the main problem that we have with this drug. Now we talk about dopamine agonists. Levodopa plus carbidopa is used, and what are the main side effect of this drug? They used to on-off phenomena, and they lead to psychosis, somnambulism, that is more and more sleepiness, confusion, hallucination, dyskinesia. And if this patient develops psychosis, then you have to add quetiapine. Well, now amantadine is again dopamine agonist drug. The side effects are ankle edema and libido reticularis. Ankle edema is a big problem. Again, a question for you. Tell me any drug which is notorious to cause ankle edema. Stop the video, write down the answer. Well, the answer is nifedipine. Or you can say it, anti-calcium channel blocker, which I use as an anti-hypertensive drug, but nifedipine is the one which is notorious to cause this problem. Well, this was regarding ankle edema. Then we talk about non-ergot alkaloids. And what are the example of this? Pramipexole, then ropinirole, rotigotine, and the new drug is apomorphine. The side effect again somnolence, hypotension, confusion, hallucination, especially in the elderly people. Then we have ergot alkaloid. They include pergolide, cabergoline. They are the newer drugs, and the previous drug was bromocriptine. Now, again a question for you. Latest update is there. Bromocriptine we have been using for ages for Parkinson, for galactoria, and so many other conditions. The question for you is, stop the video, write down the answer. What is the latest use for which bromocriptine has been approved? Well, I am sure you must have written the answer. Bromocriptine has been approved as a anti-diabetic drug. It is recently approved. Well, this is the libido reticularis that we see with the use of amantadine. I talked to you. Now, COMT inhibitor. They are entacapone, tolcapone. They reduce the breakdown of dopamine. The point to be noted, the two drugs, MAO-B inhibitor and COMT inhibitor, these are not direct the drug for Parkinson. They are always add-on drug because they are simply going to reduce the metabolism of dopamine. That's why they will cause increased level of dopamine, thereby action of dopaminergic drug will be prolonged. Well, now the new concept has come, continuous infusion of lower levodopa. This is the latest thing has come up, and what is this? This you need to understand. We'll spend time. This latest update is there. Well, if somebody asks you what is the best drug for Parkinson, beyond doubt, dopamine, that is carbidopa, is the best drug. Levodopa or carbidopa are the best drug. But what the problem with this? When the level of the drug in the blood is good, patient become all right, we call it on. but as the drug gets metabolized, level goes down, patient symptom worsen off. Again patient take a new next dose, on off. So on off phenomena is a big problem. At time patient is walking on the road and suddenly and after some time patient goes into off state. He is not even able to walk, and in that case he is simply freezed in the road or in the pavement. He is not able to move at all. So despite being the best drug, levodopa or carbidopa, they were not very commonly used. Well, another drug which has same problem was insulin, I for insulin. You give insulin to a diabetic patient, once the drug is acting, sugar level goes down, but once the insulin level is reduced, sugar goes high, low, high. So fluctuation of the blood sugar is there with the insulin therapy subcutaneous. So-called we can say that we get on and off phenomena with insulin, although just to warn you, on and off phenomena word we don't use for insulin, but just to make you understand what is the similarity in the two drugs, levodopa and insulin. Now what the latest treatment for is you use insulin pump, I for insulin pump. Advantage, it keeps on monitoring the sugar level minute to minute basis and keep on injecting the insulin level so that blood sugar level is maintained in a normal range. Now same thing, they have come with the intrajejunal infusion of levodopa gel, and of course, and this avoid the problem of gastric emptying also. Why not to oral? Because I told you these patients are prone to reduced GI movement, and that's why these patients are prone to constipation. So this is the jejunal, this is the pump that you are using. They put the dye in the jejunum, and this is the way, I hope it looks like more of an insulin pump. This is the advantage, the latest update, but not a very popular modality of treatment because it's very expensive. Not everybody can afford it, but it's a new thing. Maybe in the due course of time it will become cheaper and more popular. Now what the most talked about treatment nowadays is deep brain stimulation. What they do, they stimulate with high frequency in subthalamic nucleus substantia nigra, and that improves the outcome of Parkinson's disease. Surgery is now being tried in many cases. Stereotactic thalamotomy, pallidotomy, transplantation of fetal midbrain into the putamen of patient, transplantation of autologous adrenally medullary tissue. They are the surgical treatment done in some cases, but again not a very popular treatment, very expensive, not easily available. There are some limitations are there. Well, now we have understood the basic pharmacology of drugs. Now how to treat a case of Parkinson? Well, this depends on severity. Now new thing has come up. Suppose a patient has come in the very early phase of the disease. We give certain drug as a neuroprotection, and these drugs can delay or prevent the onset of Parkinson's disease. Okay, but remember, they are not curative. They are simply going to delay the progression of that disease. And the drug that we use in this category are saligeline, rezagiline, and coenzyme Q10. Something very interesting. This is a drug, what they say, if you use it really delays or slow down the Parkinson disease. Now again a question for you. Stop the video after listening to the question. Tell me in which other disease we use coenzyme Q10, which is supposed to improve the outcome. Although it's again not a particular disease, not a particular drug to be used in that condition also, just like in Parkinson. Well, I am sure you must have written the answer. The answer is congestive heart failure. There also we use to have a better outcome. So this for neuroprotection in the early. Otherwise, if patient come in very early stage of Parkinsonism, then what we give below age of 60 year, we use anticholinergic drug. But if the patient come above the age of 50 years, we use amantadine. And by now you are clear about it, why we do not use anticholinergic drug in a patient above 60 years. Well, patient come little late, then what to do? We use pramipexole or ropinirole, they are dopamine agonists, or we can use levodopa or carbidopa. Now either of these plus add either COMT inhibitor or MAO-B inhibitor. Now as you are, pharmacology is very clear. So now I don't need to explain to you again the why we use either of the two, because they are going to reduce the breakdown of dopamine and ultimately they are going to extend the duration of action of levodopa. Now let's talk about one more thing which is related to Parkinson is Lewy body dementia, and levodopa dementia is nothing but Parkinson plus dementia. Remember, in a routine Parkinson patient, depression is very common, but dementia is a late feature. But we have one entity called Lewy body dementia, where it is little early, cognitive function fluctuate, visual hallucination and Parkinsonism are there, and something very interestingly, cognitive function may precede or may appear along with the development of Parkinson feature. That means in these type of patient, dementia or impaired cognitive function is a very early feature. Similarly, we have a multi-system atrophy is there, so-called Shy-Drager syndrome. Other name of this condition is Shy. And in this patient has Parkinson and autonomic neuropathy, and patient also have cerebellar ataxia. But this is the very, very important feature. So whenever we are getting a patient where we are getting postural hypotension in a patient of Parkinson, you always suspect about multisystem atrophy. Okay. In addition feature, because the patient has autonomic dysfunction, this will add to not only to orthostatic hypotension, impotence and incontinence are other features which can occur in these patients, all due to autonomic dysfunction. Then we have one more entity, so-called supranuclear palsy, and also known as Steele-Richardson syndrome. And the usual age is between the age of 50 to 80 years. That means it usually occurs in elderly people and slightly more in males as compared to females. What is the classical feature? These patients have vertical supranuclear gaze palsy. So they have difficulty in looking down. They can't look down. And when should you suspect about this disease? Patient having elderly man, patient has difficulty in climbing down the stair. Climbing down. This need understanding. Whenever we climb down, it's quite natural that we look down. Okay, if not, you must, when next time you just climb down the staircase, you look it, your eyes will automatically go down. This, okay. But these patients have down gaze palsy, they can't look, so they tend to extend the body so that they can look down. But still, climbing down, they tend to fall. So friends, whenever you get a question where the elderly man tend to fall down having extended posture, you think about progressive supranuclear palsy. So we have extension, limb rigidity and bradykinesia are the feature. Tremor are unusual. And one more thing, brisk plantar is there. Cerebral signs are positive and intellectual function are impaired. Now I have a question for you. We have read the disease and we read that in case of plantar reflexes are upgoing. Now tell me what happened to power, sensation and deep tendon reflexes in Parkinsonism. You can stop the video, write down the answer. Well, I hope you have written the answer. So remember, in Parkinson, muscle power is normal, sensory system is normal, and deep tendon reflexes are normal, despite having slowness of movement, but these things are normal. This is a very, very important point that you got to remember. Well, let's have a quick recap of the last minute revision point what we learned in this particular lecture. Parkinson is caused by disturbance of substantia nigra, also called Nigro's tidal pathway, resting tremor with a frequency of 4 to 6 per second, starting in the unilateral thumb. Later on it can extend to fingers and other arm also. Tendon reflexes are normal. Plantar reflex is typical flexor. Fascinating gait. Small handwriting, so-called micrographia. Normal intelligence, but in Lewy body dementia, intelligence may be impaired. Emotional liability is very common in these patients. Depression is very common. Marked expressionless face is there, and slurred or indistinct speech is there. So-called monotonous speech is there. Neuroprotection, we use salicylic, razaglin, or coenzyme Q. Lewy body dementia is Parkinson plus dementia. Multisystem atrophy, the previous name was Scheidegger syndrome. Patient has postal hypotension, also called autonomic neuropathy, and cerebral dysfunction. And progressive supranuclear palsy is frequent fall, especially on climbing down the stairs. Thank you very much for watching this video.